my brief is basically to talk on death of Lewinnek safe zone. So the part about what we all worry about are dislocations in total hip, and they amount to about 28% in revision cases. But the good news is that 75% of them happen in the first year. So if your hips last maybe 1 year, you're through with 75% chance of success. There are very many reasons for dislocations, and component malpositioning happens to be one of the major causes. Then in 1978 came this landmark paper by Lewinnek, in which he suggested a safe zone for cup positioning to avoid impingement and dislocations, which was at 40 degree for abduction and 15 degree of anteversion in the coronal plane. Mind you, he used a jig to place the patient on the X-ray plate so that the anterior pelvic plane was parallel to the plate. This reduced his dislocation as per literature from 6.1 to 1.5%. Mind you, the scenario in 1978, CTs were not available as frequently, and now the gold standards for component positioning happen to be CT scans. There were devil's advocates that came out with these papers, and they said that only 11% of the current literature which blame Lewinnek safe zone use his criteria of using a jig of APP being parallel to the plate. Then there was a paper in 1993 by Murray, and what he thought was, if this radiological parameter that was dictated to us, does it correlate to an operative target? So he analyzed that, he gave nomograms, which gave us an operative target of what the radiological target was as measured by Lewinnek. However, still there were dislocations. And then came this paper which says, what is the safe zone? And this is an important paper because they discuss only dislocated hips in 2,700 cases, and 65% of them used by the posterior approach had safe cup positioning. 33% cups from the anterolateral approach had their cups in the safe zone. Then came this editorial of a death zone. The Lewinnek zone is no more existential. And they discussed the fallacy in that paper. Out of 300 hips, 178 hips did not have any adequate data. 3 out of 9 dislocated hips had their cups in the safe zone. And Lewinnek measured only the static pelvic angles, which were not taking into consideration the pelvic movements that we have discussed. Mind you, the editorial still holds true if we are using newer technology as well, because technology measures the anterior pelvic plane and the femoral anteversion accurately, but the functional lumbosacral angles have still to be accounted for. Then came this paper in 2013, in which they took standing films and they got these coronal as well as sagittal planes that we need to be adjusted on table. Now let's say, for example, you have an obliquity of 10 degrees and you need to adjust your cup on table by having your cup placed to the horizontal and not to the interpterygium line. And that's how they've adjusted it. So you need to reduce the inclination in this particular patient. They measured the anterior pelvic plane, marked it on table, and therefore they adjusted that using femur first technique and subtracted that from the combined version. And the cup was made parallel to the tal, used multiple landmarks, and they validated that to the correction used in the sagittal plane. So this is how the cup was placed and the adjustments were done. Anteversion, we can use various techniques. Commonly is what most of us use in the combined anteversion. There is Widmar's formula, which says that cup anteversion plus 0.7 into stem anteversion is 37.3 degrees. Or we can use these complex formulas which most radiological softwares use to analyze the cup placement. Then we have already discussed the spine-hip relationships. What is important is that they have given weightage to the pelvic tilt. And this paper also gives us a 3D diagram in which while we sit, the pelvic rocks behind, and for every 1 degree of rocking behind, you have a 0.75 degrees increase in anteversion. Mind you, if you increase the inclination, the anteversion angle increases even further. That's what Dr. Pachore sir also mentioned. Then influence of spine-hip relationship, again, it is the same paper, but very important thing that we need to discuss is stuck in sitting position that we have already discussed. Then you have the pelvic indices, how they are changed from less than 40 degrees to 60 degrees, and what are hip users and spine users, and what is their influence on their cup anteversion. Based on this, they also give us high risk zone, that is stiff hip or fused hips with stiff spines use high large head, or dual mobility cups. This is again an important paper, and we are going to introduce one more parameter to add to our thought process of a combined sagittal index, which is the CSI. And what this paper gives weightage to is the femoral motion. And this paper says that the femoral version is more important than lumbosacral version as well. And they've added this parameter called proximal femoral angle from the center of the sacrum to the center of the hip and the anterior femoral cortex. And then they measure this angle of anticlination. So this is the lateral film, as you can see. You measure the sacral slope, you measure the anticlination of the cup, and you measure the proximal femoral angle. The sum total of the PFA, proximal femoral angle, and the anticlination gives us the combined sagittal index. Now let's see the outliers. Now in the standing position, if the femur is in hyperextension, your CSI is higher, and therefore the cups can impinge posteriorly and dislocate anteriorly. In the sitting position, if you have increased femoral flexion, that means the CSI is an outlier in less than 151 degrees. It can impinge anteriorly and dislocate posteriorly. So we come to this fact, what are the predictors of CSI outliers? So whenever you have increased femoral motion in standing or sitting, that can be an outlier. A stiff pelvis, wherein the sacral slope change is less than 10 degrees, can be an outlier. And pelvic indices, which are very low, can be an outlier. So what do you do differently? That's what is the question today. How do I change my practice? We don't need to change it radically, but it's important to analyze when we need to take adequate action. So use multiple landmarks, use anatomic landmarks, validate and revalidate your cup positioning. Especially fine adjustments are required in those few difficult spatial cases. So identify those high risks of dislocations, stiff hips, low pelvic indices, and excessive femoral motion, in which we have to use large femoral heads or better dual mobility articulation, which gives us a higher jump distance. So in summary, have a good preoperative plan for a functional cup placement, identify high-risk patients, and use of dual mobility in select patients is definitely advised. And that is what we say is the death of Lewinnek safe zone today. I thank you for your patient hearing.